And thank you everyone for attending. I'm Tyler Chen from N95DECON. First of all, I just want to thank everyone who is tuning in today and everyone who is supporting all the medical workers on the front lines. Thank you so much. We're really doing this to support you in any way we can because we know you're supporting really everyone around the world right now. So thank you. Next slide, please. So I'm just going to give a brief overview of our group. N95DECON is a consortium of 105 scientists from over 10 different institutions. Our goal is to be as unbiased and as interdisciplinary as possible and find, basically put together the existing scientific literature on N95 decontamination methods to evaluate which methods have been shown to be safe and which methods have not. We have done this by publishing technical reports and fact sheets, which you can find on our website at N95DECON.org. And we have also been coordinating and executing new research to find new methods that might be applicable in different settings. We are independent, we're fully volunteer-based, and we subject all of the information in our publications to rigorous scientific review to try to give the most up-to-date and accurate information on these methods. Next slide, please. So today we're going to be talking a bit about the background behind various PPE that is used for, that's personal protective equipment that's used for COVID-19, specifically focusing on N95s. And we're then going to move to a couple of methods that we have been shown in the literature to be effective for N95 decontamination. That's UVC, heat, hydrogen peroxide vapor, and a time method of weighting and reusing. And most importantly, you should get from this some considerations to look at when evaluating an N95 decontamination protocol that may be used at your facility. So with that, I'm going to turn it over to Ashley, who will give you the introduction on PPE for COVID-19. Thank you.
Good morning. I am Ashley Styczynski. I'm an infectious disease fellow at Stanford University and also a Fogarty Global Health Scholar. So before we jump into talking about N95s, I first wanted to start with a brief overview of the necessary PPE for protecting against COVID-19 with a focus on low resource settings. Healthcare workers are especially vulnerable to becoming infected with SARS-CoV-2, as we've seen across the world in Italy, Spain, Russia, and the US. However, with appropriate use of PPE, healthcare worker infections are largely preventable even in limited resource settings. Sorry, next slide. Okay, we're there. So PPE is only one of many strategies that can be used to reduce risk to healthcare workers, and it is the least effective. PPE use should be coupled with strategies that minimize the amount of virus present in the healthcare facility. For example, using triage and cohorting systems can reduce healthcare workers from becoming exposed to potentially infected individuals. Similarly, interventions such as improving ventilation, enhancing hand washing, can lower the burden of infectious particles in the environment. Next slide. To fully understand what is the PPE that's required when caring for COVID or suspected COVID patients, you have to first understand how SARS-CoV-2 is transmitted. Here we have a general overview of the chain of infection for any type of disease. We start with an infectious agent, which in this case is SARS-CoV-2. Next. This is the virus that causes COVID-19. The reservoir of the virus can be either symptomatic or asymptomatic individuals. Estimates suggest that up to 25 or even 50% of individuals may be asymptomatic. However, they can still be spreading the virus. So we have to take this into consideration to understand who is at risk of spreading the virus. Virus typically enters the environment in the context of respiratory secretions, which can be generated by coughing, sneezing, singing, or even talking. We know that people can become infected through droplet, contact, and aerosol routes. This is because there are receptors, the ACE2 receptors, for the virus in the nasal epithelium, as well as the lower respiratory tract. Therefore, the virus does not pass through intact skin. The only way for contact transmission to occur is when the virus is passed from a surface to a susceptible mucous membrane, such as when touching one's face. We don't know the relative impact of droplet versus aerosol transmission. The major difference is how close you have to be to the source, which is about 1 to 2 meters for droplet spread, or more than 2 meters for aerosol spread. Also, the difference is based off of the size of the particles. Aerosols are much smaller and can hang around in the air for longer than droplets, which frequently fall to the ground. Right now, we believe transmission is largely driven by droplets, with some exception in the healthcare setting when aerosol generating procedures are performed, such as intubation, CPR, or collection of nasal swabs. And in terms of susceptible host, we know that anybody is potentially a susceptible host. Next slide. The type of PPE required depends on the modes of transmission that you may be exposed to. If you're entering a cohort area, for example, but have no patient contact, you only need a surgical mask as you're primarily concerned about droplet transmission. If you're providing direct patient care, you need protection against both droplet and contact transmission. So in addition to a surgical mask, you will need gloves and a gown. Additionally, because of the risk for close range droplets falling directly into mucous membranes, facial protection is also required. If you are at risk to exposure to aerosols, a surgical mask is no longer sufficient. You'll need additional respiratory protection, such as from an N95 or FFP2, to filter out smaller particles. Cleaners of COVID wards and laboratory technicians require similar levels of protection to healthcare workers, as do visitors. This set of recommendations for use of PPE during COVID is supported by both WHO and CDC. Next slide. So what is the evidence that we have for these various interventions of PPE? There was a Cochrane review looking at ways that healthcare workers were protected from infection during previous outbreaks of respiratory viruses. Most of this information was drawn from either the first SARS outbreak or for RSV that have very similar transmission patterns to SARS-CoV-2. And what they found was that frequent hand washing was highly effective at reducing risk of infection to healthcare workers. Wearing a mask was also significant, and this was actually a simple mask, so it included both a range of cloth masks and surgical masks, and they noted that these were protective. Wearing an N95 mask offered slightly more protection, although there was overlap in the confidence interval. Wearing gloves, wearing gowns, using eye protection, and interestingly, performing nasal washes, all had statistically significant protective effects for healthcare workers against respiratory viruses. Next slide. More PPE does not mean more protection. Two items that are not required to protect against COVID-19 are head coverings and shoe coverings. This is because the virus is not transmitted in a way that makes either of these likely pathways for propagating disease spread. In fact, healthcare workers are at the highest risk of becoming exposed to the virus during doffing or removing of PPE. In particular, removal of shoe covers and head covers result in some of the highest rates of self-contamination. When considering these figures, it may actually be better, maybe riskier to wear too much PPE. Next slide. To reduce the risk of self-contamination, it is important to follow safe doffing practices. The most important thing to remember is to avoid touching the outside of the PPE, which can be contaminated. Gloves should be removed first, as these are likely to be the most contaminated. You can do this by pinching in the middle of one glove to peel off the first glove. Hold the removed glove in your gloved hand and slide fingers of the ungloved hand under the remaining glove at the wrist to peel off the second glove over the first glove. The second step of doffing is to remove your face protection by lifting the head strap or earpiece from the back. The third step is to pull the gown down or away from the neck and shoulders, only touching the inside of the gown. Fold or roll into a bundle and discard. Step 4 is to remove your mask. If wearing an N95 or FFP2, you want to grasp the bottom strap and pull up over the head. then grasp the top strap to remove the mask without touching the front of the mask. For surgical masks, you can remove by grasping the ear loops. And always perform hand hygiene after removing PPE. Next slide. A question that often comes up in resource-limited settings is, what if I have limited PPE? There are 3 ways that you can continue to protect yourself as a healthcare worker, even in the face of limited PPE supplies. These strategies are inferior to using standard recommendations for PPE, but they are supported by WHO and CDC as risk mitigation strategies during times of limited resources. So the first strategy that's recommended is something called extended use. This refers to wearing PPE for longer than a single patient encounter. When you're caring for multiple patients with the same diagnosis, for example, COVID-19, you can wear the same PPE for the duration of your shift as long as it is not soiled or damaged. A second method is decontamination and reuse, and this is another way to extend the life of PPE. Decontamination reduces the risk for self-contamination, making reuse a safer possibility. However, it is important to use a decontamination method that is effective without compromising the quality of the PPE. And we'll hear more about these later in this presentation. Finally, substitution is a last resort option when there is no PPE available. And this refers to using non-standard materials to provide protection. Although PPE substitutes will offer less protection than standard PPE, they can be used to provide limited protection when nothing else is available. Next slide. Regardless of whether you have any PPE, hand hygiene remains one of the most important ways for healthcare workers to protect themselves, and we cannot forget this. In the setting of COVID-19, washing with soap and water or alcohol-based hand rub are considered equally effective methods for hand hygiene. In a recent study of risk factors for healthcare workers becoming infected with SARS-CoV-2, suboptimal hand washing was on par with improper PPE use. This is a reminder that the basics of infection prevention still hold true and remain of paramount importance for protecting healthcare workers. Next slide. One of the most critical components of PPE to protect healthcare workers is use of a face mask. This is because droplet and to some extent aerosol transmission are the main drivers for SARS-CoV-2 spread. N95s, KN95s, and FFP2 masks offer the greatest protection against both droplets and aerosols. As such, they should be reserved for use during aerosol generating procedures. A surgical mask provides protection against droplets. This is an appropriate level of protection for most activities in the healthcare setting. A cloth mask should only be considered if no surgical masks are available. Per WHO recommendations, N95, FFP2, and surgical masks can be worn for up to 6 hours at a time. I won't discuss decontamination of N95 since we will be going into that more in more detail later in this webinar. For surgical masks, only CDC at this point allows for limited reuse. This is because there are no validated decontamination methods. So WHO recommends discarding surgical masks after each use to minimize the risk of contamination to healthcare workers. If you are to reuse the mask, you need to remain mindful that the outer surface could be contaminated. Therefore, to store the mask, you should fold it in half so the outer surface is touching itself to minimize your risk of coming into contact with the virus. And always wash your hands after removing a mask. If no N95 or FFP2 masks are available to you and you must perform an aerosol generating procedure, surgical masks offer the next best protection, particularly when combined with a face shield. Cloth masks should always remain a last resort. Next. If you must use a cloth mask, a tightly woven cotton, especially when combined with other types of fabric, can provide reasonable filtration efficiency. However, effectiveness will depend not only on the type of cloth, but also on a secure fit around the mouth and nose. Notice that in this graph of filtration efficiency of various materials by particle size, that even with an N95 mask, gaps substantially decrease the effectiveness. So the design of the mask is as important as the material. Next slide. The main purpose of gloves is to reduce the amount of virus that ends up on your hands. However, remember that virus on your hands does not in itself lead to infection unless your hands contact a viable source for infection, such as your mucous membranes, your eyes, nose, and mouth. The same reduction in virus can also be achieved with extended duration of hand washing, say for 1 to 2 minutes. Therefore, gloves are primarily a way to enhance your hand hygiene. The ideal practice is to change your gloves between every patient to ensure that you're not spreading infections between patients. However, if you have a limited supply of gloves, research has shown that alcohol-based hand rub can be applied to latex and nitrile gloves up to 30 times without compromising the protection of the gloves. If you have absolutely no gloves available, extended hand washing can provide equivalent protection. Next slide. A face shield or goggles is recommended to reduce the risk of droplets directly contacting the mucous membranes of the eyes, such as if someone sneezes or coughs nearby. Is there a difference between goggles and face shields? Yes and no. Both WHO and CDC recognize goggles and face shields as sufficient eye protection. However, we know from other studies that face shields can reduce the risk of contaminating the outer portion of masks. Since doffing is a high-risk procedure for virus transmission, reducing external contamination can minimize risk to healthcare workers. Additionally, face shields offer 68 to 96% reduction in aerosol exposure, so they can enhance the efficacy of face masks. During the first SARS outbreak, researchers found a 3-fold reduction in SARS infections among nurses who wore face shields compared with those who do not. So face shields also prevent people from touching their faces, which can minimize self-contamination. Furthermore, they can often be locally produced with inexpensive materials. Either a face shield or goggles can be reused indefinitely as long as viability is not compromised. Decontamination can be performed with 70% alcohol solution, 0.5% chlorine, or just about any hospital detergent. This should be performed at least daily. Your choice of cleaning agent will depend on what's available to you and whether it compromises the visibility or quality of the eye protection. If you find yourself without either a face shield or goggles, there are many options for making your own face shield, such as with a 2-liter soda bottle. As long as it covers from forehead to chin and ear to ear, it can be effective. Next slide. A gown is intended to reduce contamination of clothing and subsequent contact transmission. There are no specific recommendations by CDC or WHO on acceptable gown material. The only requirement is having a waterproof protection if splashes or sprays are anticipated or during aerosol generating procedures. A gown can be worn for the duration of a shift unless soiled. If it is a reusable gown, it should be laundered at least daily. If no gowns are available, substitutions such as lab coats, aprons, or layered clothing can be considered. Next slide. We've summarized these recommendations into an infographic that we can share if this would be a useful resource to post in your healthcare facility. Next slide.
Thank you so much, Ashley, for your talk. At this time, we're going to take a couple questions. First, I'll just introduce myself briefly. My name is Marianne, and I'm a grad student at Stanford. Lynn, would you like to introduce yourself?
Hi, everybody. My name is Lynn Stoller, and I work in public health practice here at N95DECON.
Thank you so much, Lynn. For the sake of time, we're just going to ask one question that was asked in the chat. Ashley, should goggles be removed right before the face mask to avoid spillage from the overalls into the eyes?
Should goggles be removed before the face mask? Yes, goggles should be removed before the face mask. Hopefully there is not a lot of spillage. I'm not exactly sure what that means, but taking the goggles off before the face mask is the correct order.
Thank you so much, Ashley. So I think now we're going to be ready for the next talk by Kezi.
Hi. Hi, my name is Kezi Cheng. I am also part of N95DECON. I am a material science PhD student at Harvard University, and today I'll be discussing the background on N95 masks before we dive into decontamination methods. Next slide, please. So in this picture, there are many types of masks that range in the protection it provides the users. From on the left side, you see medical masks as well as homemade cloth masks. And on the right, we have very high protection, such as the powered air purifying respirators. And in the middle, the red and the orange boxes, we have masks where most particles are removed and filtered out. So these are the filtering facepiece respirators, such as the N95s. These N95s typically do not protect against gas or vapor. In the orange box, we have elastomeric respirators. So under typical situations, N95s are disposable, whereas elastomerics can be reused for non-biohazardous work. Today, we will focus on FFRs, particularly N95s that could be reused and decontaminated due to supply constraints around the world. Next. As you saw on the previous slide, there are many models of N95s. And in addition, there are also many international equivalents of NIOSH-approved N95s, such as the European FFP2 respirators, as well as the Chinese KN95s, the Australia P2s. However, a lot of these FFRs are designed for a range of other purposes, for example, filtering non-oil-based particles, such as those resulting from wildfires, PM 2.5 air pollution, or bioaerosols. And they're also tested under different requirements. So on the table on the right, you can see that some of these masks are tested under different flow rates for filtration efficiency and pressure drop. So prior to selecting a respirator, users should really consult with their local public health authorities for selection guidance. Next. There are a number of documents updated by the FDA and CDC regarding N95 equivalents, such as a list of counterfeits and misrepresentations of NIOSH-approved masks. There's also an updated document on the EUA for authorized import non-NIOSH-approved FFRs from other countries and also from China. So please take a careful look at these documents before selecting or purchasing N95 equivalents. Next. So the name N95 respirator is pretty descriptive of its functionality. The N stands for non-oil resistant. So if you have a R or a P respirator, that stands for oil resistant and oil proof, respectively. The number 95 stands for 95% of the particles being filtered out, and 100 means greater than 99.7% filtration. Respirator implies that all inhaled air is filtered if worn properly, whereas masks imply a barrier and surgical implies hydrophobic splash barrier. Next. The N95 respirator is worn to protect people from hazardous substances while allowing airflow. It does not protect users from vapors or gas. Particles in the air that contain virus could come in many droplet sizes and are not necessarily all as small as the virus. And this could be produced by breathing, coughing, or speaking by an infected person. Breathing in these particles through the nose or the mouth, or transporting particles by touching your face is the primary transmission pathway for COVID-19. Next. The two important functionalities of an N95 is having a good seal around the face and a good filter such that harmful particles do not go through the mask. The N95 consists of several layers, of which the middle one act as a filter layer and the outer and the inner are there for support and comfort. These layers are made of polymeric materials, and there's typically an aluminum nose clip that modes to a nose for a better seal. which could actually be a potential barrier for the microwave method of decontamination. The straps are either around the ears or behind the head to hold the mask in place. And in some N95s, there is cellulose material, and cellulose is incompatible with hydrogen peroxide vapor decontamination method. Next. So in the filter layer, there is an electret filter media that is made of a melt-blown, non-woven polypropylene material. This material traps respiratory droplets by electrostatic charge attraction, and therefore fibers can have a relatively large pore size for airflow and breathability. A tight seal is equally as important, and users must perform seal check qualitatively each time they don a mask, and also a fit test once a year. Filter efficiency can be greatly reduced through physical damage of the mask or loss of charge. And seal can be greatly reduced through improper donning, as well as poor fit, facial hair, structural degradation of the mask, straps, and the nose piece. So to summarize, when we think about decontaminating these masks, in addition to getting rid of the virus that might be present, it's also essential to ensure both fit and filtration standards are preserved after the decontamination process. Next. Respirators that protect you from inhaling particles have been designed for different types of settings. Here on the left, we have a respirator intended for medical use, whereas the one on the right is designed for industrial use, like sanding. And the key difference here is a valved versus a non-valved N95. The vent allows unfiltered exhalation, which should not be used for a healthcare setting. Next. So in the previous slide, I mentioned counterfeits of N95s. It's important to do mask validation through batch testing of masks. There are some ways that manufacturers validate if masks meet spec, and these can be performed either in labs or through third-party vendors. And you can find the specification using the NIOSH standard TSI 8130. The filtration efficiency is the percentage of particles that are blocked by the filter. And to measure filtration efficiency, N-series FFRs are tested at a flow rate of 85 liters per minute using a charge neutralized polydispersed sodium chloride aerosols. So N95s achieve particle filtration efficiency of greater than 95% for particle sizes ranging from 0.02 to 0.3 microns. These masks are also tested for pressure drop, which is the resistance to airflow across the mask. A greater resistance means that it will be harder for the wearer to breathe. Next. Okay, so we're pausing for discussion.
Wonderful, thank you, Kezi. We have a couple of audience questions. The first is going to be related to alternatives to N95. So due to the shortage of N95 respirators, we're seeing a lot of KN95 masks. And are these equivalent to N95 in terms of reuse and decontamination?
Sure. The FDA just provided an updated list of effective KN95s because many of the ones on the market have either been counterfeits or they have not been up to the NIOSH standards in performance. And I've provided that link, I think, in the slide, so you can go back and take a look at that. In terms of decontamination methods, as long as the KN95 has been NIOSH authorized and approved, as well as verified for filtration and fit, and does not contain cellulose, the decontamination methods that we will talk about in this presentation should become comparable to the N95s.
Great, thank you, Kezi. Due to time, I think we're going to be moving on right now to a section presented by Dr. Nichole Starr.
Hi there, good evening. I'm Nichole Starr. I'm a general surgery resident at UCSF, and I'm the Senior Research Fellow at Lifebox Foundation. Today, I'm going to be sharing some information about ensuring you have the right fit of your N95 mask, as well as proper donning and doffing technique. Next slide. In the United States, fit testing for N95s is a required procedure, and this determines which model and size of N95 mask fits your face to ensure a tight seal. However, fit testing is rarely used in low resource settings, so I want to explain the process in detail. In order to do a fit test, first the user puts on a non-breathable hood similar to the one you see in this photo. The tester then sprays either a bitter or sweet tasting aerosol substance under the hood, so the user has a baseline of what taste to expect. The user then puts on an N95 mask and the process is repeated. This time, the user should not taste the bitter or sweet taste from the aerosol if the mask fits properly. They also perform head turning and other maneuvers to make sure that moving the head doesn't allow any aerosols to enter. If the user tastes the substance, they should adjust the straps, the mask position and nose piece, or try a different size or model until the test is passed. Once the user has a passing test, they should use that mask type and size going forward. Next slide. The donning, seal check, and doffing process is critically important to protect healthcare workers from aerosol transmission of illnesses. The key concerns of this process should be ensuring proper fit of the mask and preventing self-contamination. The seal check is an essential step, and it ensures you have a tight seal to the face and that aerosols cannot enter around the edges of the mask. This should be done every time you don the mask. To don the mask, use clean or gloved hands to cup the mask like you see here. Place it over your face and pull the upper strap over the crown of your head, followed by the lower strap down to your neck. Adjust the straps so that they're straight, and adjust the mask so it covers your nose and chin. Then press, don't pinch, the nose piece so it fits the bridge of your nose. You're then ready to perform a seal check, and this can use positive or negative pressure. For a negative pressure seal check, place your hands around the edges of the mask and inhale. You should feel the mask seal to your face and bow slightly inwards, and you should not feel air escaping in around the edges. And this is the proper seal check for N95 masks with exhalation valves. For a positive pressure seal check, you exhale against the mask. You should not feel air escape around the edges of the mask, and you should feel it generate a slight positive pressure inside the mask before the seal is broken. To doff or remove N95s, care should be taken not to contaminate yourself. You should remove the mask after you exit any patient area where aerosols may be present, and you should assume the front of the mask is contaminated. Perform hand hygiene first, then remove the lower strap. You want to grab the straps towards the back of your head, not near your face where they could be contaminated. Remove the lower strap up and over your head. This prevents the mask from falling forward onto your chest. Next, remove the upper strap and lift the mask away from your face and place it into a clean container for decontamination. Next, perform hand hygiene before touching anything else. Next slide. There are recommendations from the CDC on extended use or reuse of PPE during the COVID-19 pandemic and resulting shortages, as was previously discussed by Ashley. Conservation strategies for N95s should also include limiting the personnel or clinical situations where N95s are used. Extended use is an option, meaning wearing the mask for longer periods of time without taking it off, and it has less risk of self-contamination than reuse, which involves multiple donning and doffing cycles. If reuse must be employed, which means donning the N95 mask again without decontamination between patient encounters, you should make sure you have the proper storage containers and don't share masks between users. Next slide. If masks will be stored and used, there are some important considerations. The containers must be breathable. Consider using a plastic container with holes punched in the top or a cardboard takeout container. This will prevent the growth of mold or bacteria on the mask during storage. Placing the mask face down and securing straps over the sides, as you see in the photo, also prevents the contaminated side of the mask from touching multiple sides of the storage container. Make sure you either dispose of or decontaminate storage containers after every use. Do not reuse heavily contaminated N95s. For example, those used in aerosol generating procedures. These should be decontaminated right away. Don't share N95s between different users, and don't let the straps touch the front of the mask, as this will increase the chances of self-contamination. Next slide. N95 masks can be set aside for decontamination either after aerosol generating procedures or after a certain time period of wear as designated by your hospital. N95s that are obviously soiled on the outside with blood or body fluids, or on the inside with makeup, oils like gasoline, or are deformed or torn should not be decontaminated. These must be thrown away. Now we'll pause for another brief Q&A session before moving on to the decontamination method specifics. Thank you.
Thanks so much, Nichole. We have a question that's related to a common practice that we see. Does wearing a surgical mask, cloth mask, or face shield over an N95 extend its life?
Great question, and this practice has become pretty commonplace in a lot of hospitals. As Ashley mentioned, the use of a face shield over N95 respirators is part of the recommendations in the CDC extended use guidelines and can help protect that mask from decontamination. In terms of wearing a surgical mask over the N95, there is one publication with a small sample size that demonstrated wearing a surgical mask over the N95 didn't increase any physiologic or psychologic stress on the healthcare worker, which you might think would be a risk of increased work of breathing or CO2 retention under the mask. So either of these strategies could be used to extend the life of your mask, but this just prevents gross contamination of the outside of the mask that would prevent it from being decontaminated. It won't have any effects on sparing the physical deformation that results from multiple cycles of donning and doffing.
Thank you so much, Nichole. I think we're right now ready for Tyler's talk.
Awesome. Thank you so much, Nichole and Marianne and Lynn. So now we'll get into the meat of the N95 decontamination methods and principles. So to start off, actually, sorry, I forgot to introduce myself. I'm Tyler Chen. I'm a PhD student in bioengineering and Knight Hennessy Scholar at Stanford University. And we're going to start off with the principles, general principles that you should think about when evaluating N95 decontamination protocols. These are filtration, fit, again, but they're quite important. So next slide, please. So let's start off with an overview of each of these. So when evaluating different N95 decontamination methods, the key elements to consider are, first of all, the method must not damage the N95's ability to filter particles. Secondly, it must not damage the N95's fit, that tight seal to the face that you're checking with a user seal check that Nichole showed. Most importantly, the method must reduce bioburden on the N95. That means it certainly needs to inactivate the SARS-CoV-2 virus. And if possible, decontamination should also inactivate other pathogens as well. When decontaminating and reusing masks, it's important to consider the risk of infection, not only from SARS-CoV-2, but also from other pathogens that might contaminate the mask during reuse. And finally, the decontamination method should not leave hazardous residue that could pose a threat to the healthcare worker who's using the method. In the evidence sections of this presentation, we're going to talk about the evidence supporting 3 decontamination approaches, as well as some of their risks and limitations. And it's important to note that the majority of the sources we're citing in this presentation are peer-reviewed or have been implemented by hospitals, but there are some studies which have not yet been peer-reviewed, and we denote those with an asterisk. Next slide, please. So let's start off with filtration and fit. When considering how the decontamination is going to affect the N95, it's unfortunately quite important. It's quite dependent on the decontamination method that's used and on the N95 model that's used. So we'd like to say that there's some one-size-fits-all method, but unfortunately, it's a little bit more complicated than that, and it's very important to make sure that a decontamination protocol you're using will not damage the filtration and fit. The number of cycles of decontamination an N95 can go through before it is damaged beyond the ability to reuse it again is dependent on the decontamination method and the model that's used. And you can find a large list of the various methods and the masks they've been tested for at our website, N95DECON.org/publications. So even without decontamination, some N95 models lose their fit to the face just after donning and doffing, putting it on and taking it off 5 times. And others lose their fit after over 15 donning and doffing cycles. So this just highlights, even without decontamination, it's very, very important, regardless of setting, to use the user seal check to make sure the mask is still fitting to the face anytime that it's being reused. Next slide, please. So now let's move on to the third criterion, which is bioburden reduction. In evaluating how effective a method is for decontamination, it's important to consider the hierarchy of resistance of pathogens to disinfection. So some of the hardest organisms to kill are bacterial spores. So higher level disinfection methods can achieve a 6 log reduction in viable bacterial spores. Log reduction here is defined as a 10-fold decrease in the concentration of the pathogen. So therefore, a 6 log reduction effectively should reduce 1 million active pathogens down to 1 or less. So with decontamination, our primary goal is the decontamination of N95 respirators for use against SARS-CoV-2. So the decontamination method must, at the very least, inactivate the SARS-CoV-2 virus. This virus is an enveloped RNA virus and is relatively low on the resistance scale. You can see boxed down there at the bottom. The FDA recommends at least 3 log reduction is demonstrated against the virus for emergency use authorization of decontamination procedures, which is defined as being able to reduce 1,000 viable viruses down to 1 or less. Now, it's important to note some of the methods we discussed, such as humid heat, may achieve 3 log reduction of SARS-CoV-2, but may not inactivate other bacteria and pathogens. So these may remain a concern if you're using these methods for decontamination. Next slide, please. So this is a very important slide. There are certain methods that have been shown to be ineffective for decontamination. These are likely not effective because they either damage the N95 filtration or do not sufficiently inactivate the SARS-CoV-2 virus. The methods that damage the N95 filtration are soap, alcohol, bleach immersion, and gamma radiation. These have been shown in peer-reviewed literature to damage the N95 filtration and should not be used. Some other methods that do not inactivate the virus, for example, are overnight storage. Storing a mask overnight does not allow enough time for the virus to inactivate on the surface, so that is not sufficient. Similarly, UVA and UVB sources, we'll go into this a little bit more in the next couple slides, but things like nail salon and tanning beds are not sufficient. They do not deliver enough UVC germicidal dose to the mask in order to inactivate the virus. Similarly, sunlight there's not been any studies showing that sunlight will deliver enough dose to inactivate the virus. Finally, it is important to note that contaminated masks should not be brought home, since this carries significant contamination risk. And decontamination should occur only in a secure environment, such as a hospital or a third-party provider. Next slide, please. So here's a summary of the decontamination principles. Again, it's very important to remember if evaluating the decontamination that's happening at your facility, it needs to preserve the N95 filtration, needs to preserve the N95 fit, and it needs to sufficiently inactivate at the very least SARS-CoV-2 to a 3 log reduction level, and preferably a sterilization method should be used, which achieves over 6 log inactivation of bacterial spores. And finally, hazardous residues should be minimized so that there's no inhalation or contact hazard for the healthcare worker that's reusing the mask. So I'm going to go now into the decontamination methods. Specifically, we're going to start off with vaporized hydrogen peroxide. Next slide, please. So vaporized hydrogen peroxide is a highly effective method at inactivating both virus and bacterial spores. This method uses specific instruments from companies including Bioquell and Steris that generate hydrogen peroxide vapor. Hydrogen peroxide is a strong sterilant and reacts with many biological substances to produce reactive oxygen species that destroy membrane lipids proteins, and DNA and RNA. One benefit of hydrogen peroxide vapor is that it can penetrate dark spaces unlike light, and the final breakdown products are non-harmful, which are water and oxygen. This method, as you can see on the left, has been shown to inactivate SARS-CoV-2 as well as more resistant organisms such as bacterial spores on the surface of an N95 after a manufacturer-approved cycle. And it's been shown as well that these methods do not damage the N95 filter or the straps of the N95 after 20 cycles, though it is important to remember that just donning and doffing alone may reduce the N95 fit. One other important thing to note is that hydrogen peroxide is a respiratory hazard and requires very controlled airflow for application and sufficient aeration duration of the mask. So the mask needs to be aired out for some amount of time after the vaporized hydrogen peroxide is applied to ensure that there's no residue that might harm the user. And finally, hydrogen peroxide vapor requires equipment that is usually expensive and does require trained personnel. So these equipment protocols must be followed directly. Hydrogen peroxide is incompatible with cellulose, so it's very important as well to check if the N95 you're using does contain cellulose. And there's a list on our website at N95DECON.org/hydrogen peroxide that has a comprehensive list of N95 masks and whether or not they contain cellulose. Next slide, please. So this is just a quick summary of what I've said earlier. So in summary, if properly executed, vaporized hydrogen peroxide may inactivate viruses and bacterial spores by greater than 6 log, making it a highly effective method at decontamination. But it's important to include a biological or chemical indicator for each cycle to make sure that the sufficient hydrogen peroxide dose was delivered. N95s have been shown to preserve fit and filtration for up to 20 cycles, so long as they do not contain cellulose. And specific methods have specific cycle numbers that are allowed, and those are listed on our website at N95DECON.org. It's very important to ensure the proper aeration time of the N95 before reuse. One question that's come up quite a bit is about the use of liquid hydrogen peroxide for lower resource settings. It is true 6% liquid hydrogen peroxide may be an accessible method, but unfortunately has not yet been validated for the required aeration time after the mask is immersed in liquid hydrogen peroxide to ensure that the healthcare worker is not getting hydrogen peroxide on their face. And it has also not yet been validated for viral inactivation, although these studies are in progress. Next slide, please. So next we're going to talk about a second method, which is ultraviolet-C irradiation. So you may have heard about ultraviolet UV decontamination. Specifically what this refers to is the germicidal UVC region of the electromagnetic spectrum. So if you see the purple bar there, that's the location in the electromagnetic spectrum we're talking about here. So if you look on the far right side, the different colors or wavelengths of visible light are shown. And as we move down to lower wavelengths, which are higher energy, we pass through the UVA and UVB regions, which are non or minimally germicidal, and then finally into the UVC region, which is germicidal. So it's a good question to ask, why is it specifically this UVC light that must be used to decontaminate? And the reason is if you look right below that, right below the purple line, you see there's a germicidal action spectrum, which means how effective the light is at killing a virus or a bacterium. And you see there's a peak around 260 nanometers, right where that arrow is pointing. And the reason is this 260 nanometers is most readily absorbed by DNA and RNA, which is the mechanism of how UVC irradiation inactivates pathogens by destroying their genomic material. So the heightened efficiency in this range is why the germicidal UVC region is used and not UVA and UVB, because they don't have as much effect on the DNA and RNA of the pathogens. Next slide, please. So talking a bit about the coronavirus inactivation of this method, when you're within the germicidal UVC range of light, the evidence from peer-reviewed literature suggests that an irradiation dose, which represents the integrated intensity of light delivered to the N95, so the total dose of light that is delivered to the N95 over a given time from a given UVC source, of at least a minimum of 1 joule per centimeter squared is required to inactivate viruses similar to SARS-CoV-2 on N95 material. So there are a couple important notes about this. This dose of 1 joule per centimeter squared is much higher than doses that are that are suggested for surface decontamination. The reason is it's hypothesized that as light passes through the N95, it is attenuated, so inner layers of the N95 may not receive the same dose as the surface. Therefore, it's very important to make sure that that 1 joule per centimeter squared is delivered to the surface of the N95 to ensure that the inner layers are getting sufficient dose for germicidal activity. Secondly, the N95 straps may not be as effectively decontaminated with UVC, so the straps may require a secondary decontamination, such as wiping with a disinfectant. It's worth asking whether or not these high UVC doses will damage the mask, but it's been shown in peer-reviewed literature that the N95 will maintain fit and filtration performance after 10 to 20 cycles of 1 joule per centimeter squared. With that in mind, we anticipate that the limiting factor for reuse will be fit degradation from just donning and doffing alone. But it's very important to do the user skill check between uses. All of this evidence and more can be found at N95DECON.org/UVC in our technical report, which goes into much more detail on each of these literature. Next slide, please. So to summarize, this evidence suggests that a germicidal UVC dose of at least 1 joule per centimeter squared delivered to all surfaces of the N95 is likely to sufficiently inactivate viruses such as SARS-CoV-2 on N95s, although the bioburden reduction will depend on the N95 model used. Again, I'm going to emphasize that this dose of 1 joule per centimeter squared is crucial to ensure that it is fully decontaminated, and it must be validated with a calibrated UVC specific sensor. So that's a sensor that is not sensitive to UVA or UVB, but instead is specifically reading out the amount of UVC dose that's delivered to ensure that the mask is fully decontaminated. This is very important. So at these doses, we expect that the N95 will maintain performance up until it is damaged beyond repair from just donning and doffing alone. And it's also important to note that UVC is hazardous to human cells, just as it is harmful to pathogens. So engineering controls and PPE are crucial to make sure that no humans are exposed to UVC. Finally, there are several UVC sources such as home UV, that's the nail salon or tanning salon that I mentioned, sunlight, and sources outputting lower wavelengths UVC are not appropriate for UVC decontamination. Next slide, please. So finally, I'm going to talk about our third method, which is humid heat for viral inactivation. So what we see here in this spectrum is on the lower end, we have lower temperatures. There is a risk of reduced viral inactivation. So the SARS-CoV-2 virus can be inactivated by sufficient heat, sufficient time, and sufficient humidity altogether. But at lower temperatures, the virus will not be as readily inactivated. At higher temperatures, the virus will be inactivated, as you would expect. Higher temperatures are going to kill the virus more quickly, but unfortunately, higher temperatures also risk damage to the N95. So this one, even though it seems like a very easy one-size-fits-all method, it's actually very important to tune your heating and humidity parameters very carefully within this target range to make sure that you're inactivating the virus, but are not destroying the N95 mask. So given this, our target range is going to be 70 to 85 degrees Celsius with a target humidity of 50 to 85% and a time greater than 1 hour for sufficient inactivation without damaging the N95 mask. Next slide, please. So where do those numbers come from? First of all, there is very little data on inactivation of SARS-CoV-2 with heat, but with the little data we do have, there have been some studies that show 7EC dry heat for 1 hour successfully inactivated SARS-CoV-2 on an N95. However, this, while you may think, oh, this is great, 7EC for 60 minutes without any humidity is sufficient. However, this was only under lab conditions and real life conditions where the virus may be contained in mucin or in other, a sneeze droplet that may contain different proteins may stabilize the virus. So it's important to exceed these parameters sufficiently to make sure that you're actually inactivating the virus with some degree of safety. It's also been shown in literature that higher humidities inactivate virus with heat more readily. That's been shown specifically with flu viruses. So it's expected that with SARS-CoV-2 as well, increasing the humidity will also increase the rates of inactivation. With regards to N95 mask integrity, several N95 models have been shown to maintain fit and filtration performance after multiple 30-minute cycles at 70 to 85 degrees Celsius and 50% humidity. So cycle counts are going to depend specifically on the N95 mask that is used and the specific temperature that's used, but you can find more of the specifics of that at our website, again, N95DECON.org/heat, in our technical report, which discusses all of these. Next slide, please. So again, promising conditions for SARS-CoV-2 inactivation are likely to be 70 to 85 degrees Celsius with greater than 50% humidity for over 30 minutes. But the data here is still very limited. And it is important to remember that this heat and humidity will not necessarily inactivate all other pathogens. So bacterial spores, for example, may still be present on the surface of the mask after decontaminating. These methods have been shown to maintain fit performance for many N95s. And there are some protocols that you can see on our website as well that are relatively easy to implement. But it's very important to measure the temperature and humidity with a calibrated sensor to ensure that you're not risking damaging the mask or not getting enough heat to inactivate the virus. Another common question with regards to the heat method is, can I use an autoclave? Unfortunately, we have seen in the literature that molded N95s, so the ones that look like a cup around the face, have been shown to fail fit tests after just one cycle of autoclave. So unfortunately, those N95s cannot be put in the autoclave without destroying the mask. For pleated N95 models, so it's a slightly different look of the N95, these have been shown to potentially maintain fit from an autoclave, but the filtration early studies suggest filtration may be reduced. So currently there's no N95 that we've seen that has been consistently validated in the literature for autoclave. So we would recommend instead looking at the implementation criteria for heat and humidity that are listed here. Next slide, please. So finally, sorry, this is a lot of decontamination in one go here, but finally, if there is no other choice, the CDC has also listed storing an N95 at room temperature for multiple days as a method for possible decontamination. Unfortunately, there's very little data on how long an N95 needs to be left at room temperature to kill the SARS-CoV-2 virus. So from the few data points we do have, it seems that storing the N95 in a clean, breathable container, such as the ones that Nichole showed earlier in the presentation, storing it at room temperature for 7 days may inactivate the virus, while storing just overnight is certainly not enough to inactivate the virus. So the suggested method, if there are no other options for decontamination, is to store a mask and rotate out between which N95 you're using, if that's possible, and storing a mask for at least 7 days to ensure that the virus is likely inactivated before putting it back on and reusing it. Although, if possible, other decontamination methods, such as the ones listed earlier, heat, hydrogen peroxide, and UVC, should be used to reduce the risk of cross-contamination, or of contamination from the virus. And finally, it's important to remember that this method will certainly not protect the wearer against bacteria or mold that may be on the N95. And the N95 should be returned to its original owner to maintain fit and to prevent contamination. All right, that's it for me and decontamination, but you can find a lot more information on this on our website at N95DECON.org. And we have a longer webinar that we did with MGB that you can find also on our website or on our YouTube channel, which is, I believe, N95 Outreach. And you can find that on our YouTube channel, which goes into more detail on the actual implementation of each of these methods. So with that, I'm going to open it up for questions. Thank you so much.
Awesome. Thank you so much, Tyler. That was a great overview of the different decontamination methods that we will be discussing. The first question that we have is about heat. So can N95 masks be boiled directly?
That is a great question. Unfortunately, I have not seen any data yet that suggests that boiling the N95 directly will allow it to maintain filtration performance or fit. So unfortunately, that is something that would probably not be the best idea. Instead, if there is a heat method that would be desired, it would be more likely to be effective if it were using the 70 to 85 degrees Celsius and high relative humidity protocol that we suggest here. And I see one question actually recently in the chat that Dr. Peter Tsai recently published, COVID-19 is dead after 3 days on N95 masks. Yes, that is true. Currently though, unfortunately, the literature is skewed. We have multiple reports. Some reports suggest that 3 days is sufficient, whereas other reports have seen COVID-19 surviving until 7 days on the surface of a mask. So none of this literature is peer reviewed. So unfortunately, since we're getting these mixed reports, we think it's very important to make sure that we're not relying too heavily on any one of them.
Wonderful. Thank you so much. Next, I think Marianne will be taking the next question.
Yes, right now I have a question for Samantha. Samantha, how much time is it necessary to decontaminate an N95 mask using UVC light?
I might actually put this one over for Sam, if that's okay. Yeah, this is a great question. So an important thing to realize about UVC decontamination is that it's really the dose, which, as Tyler mentioned, is the integrated UVC intensity during the treatment time that's necessary for decontamination. So thinking about the time alone isn't sufficient because the timescales can really vary depending on the irradiance that's incident on the N95 surface. And this is something that depends not only on the source itself, but also on factors like N95 placement and operating conditions. So if you have further questions about this, we have quite an extensive write-up on the N95DECON website about UVC details.
Thank you so much, Anjali. Lynn, do you have the next question?
Yes, so we have a question for Dr. David Rempel. So Dr. Rempel, we have a question that says, are there any studies on the effectiveness of using ozone to decontaminate FFPs?
Yeah, that's a great question. There are very few studies on using ozone for decontaminating N95 FFPs. And at this time, we don't recommend using it because it could damage the electrostatic membrane in the filter, depending on the dose. And there's no evidence of decontamination of masks that are inoculated with SARS-CoV virus. So at this time, we don't recommend ozone.
Wonderful. We also have a follow-up question with vapor hydrogen peroxide. So are there current studies going on regarding vapor hydrogen peroxide decontamination in masks of HCP? There have been some reports regarding problems with masks fitting after their second cycle in the US.
There are some masks that appear to be deformed with hydrogen peroxide with relatively few treatment cycles. One of the systems for hydrogen peroxide is called STERAD. And at this point, we only recommend 2 cycles of treatment. Other hydrogen peroxide vapor systems can decontaminate for up to 10 or 20 cycles without deforming the mask or breaking down the barrier in the mask.
Wonderful, thank you.
All right, we have a question now for another technical expert that we have on the call, Chris. Chris, do you know anything about chlorine dioxide? Is chlorine dioxide a safe way to decontaminate N95 masks?
So the literature is very limited on N95 decontamination with chlorine dioxide. In fact, I'm not aware of published results for COVID-2. On the other hand, chlorine dioxide above 65% relative humidity at room temperature is a very effective sterilant against bacterial spores and therefore presumably against most bioburden. So I think it's likely that it will become a viable alternative, but at this point it can't be recommended because there is no published data. It does not damage the filtration efficiency, but that's unpublished data, and fit is an open question.
Thank you so much, Chris, and to David and Anjali, our other technical experts that we had on this call. I think that's all the questions that we have for now, and I think we're going back to Tyler to wrap things up.
Awesome. Thank you so much, Marianne. So I guess we'll start off. There is a, oh, okay, sure, I'll go to thank you. So yeah, first of all, thank you so much for everyone that has attended. We understand this was a very high rate of information transfer to you. So take time to absorb it, think about this, and you can feel free to reach out to us at any of these methods that you see here. So we have Twitter, we have an email, and our website is really where you're going to find a lot more information than we were able to deliver in this short amount of time. So on our website, we have a lot more technical reports, so detailed technical information, as well as some handy fact sheets, similar to the one that Ashley showed you earlier. That one is also going up on our website relatively shortly. And a larger webinar that includes more details on implementation, as has been carried out in various hospitals in the US. So thank you so much. Please reach out to us if you have any more questions, and really we're here to support you in any way we can. Secondly, there's a WhatsApp group that's been created by the ASSIST team. So if you have more questions regarding this session or caring for COVID-19 patients in general, they're building a community around this, and I think that's really great. So please feel free to join this WhatsApp group and start contributing to the community that way.